Thank you. So Dr. Sakuraba and I will be discussing the postoperative patient with Crohn's disease. So we have a 46-year-old male with ileal Crohn's disease. He was initially diagnosed at 24 years old in 1989, and he was poorly controlled on mesalamine for many years. And then in 2001 developed an enterovesicular fistula and underwent ileocecal resection and continued mesalamine postoperatively. In 2003, a colonoscopy shows recurrence that is anastomosis. And then years later in 2010, a colonoscopy shows ulcerated and narrowed anastomosis with normal neo-TI, and at this point he's symptomatic. The following year, he develops an intra-abdominal abscess, and following his IND, he develops an enterocutaneous fistula, and he's referred to the University of Chicago for further management. So in 2011, he undergoes a right hemicolectomy with ileal resection and enterocutaneous fistula takedown. He starts azathioprine, but discontinues it due to intolerance, and starts infliximab shortly thereafter. And then in January of 2013, so at 13 months post-op and 6 months after starting infliximab, he has a colonoscopy. The colonoscopy shows a widely patent anastomosis with scattered ulcers and aphthay extending 15 centimeters, equivalent to a Rutgers I2 recurrence, but his colon is otherwise normal. Dr. Sakuraba.
Thanks, Dr. Sophia, for presenting the case. And so today's key points would be we're going to focus on prevention of post-operative recurrence, and there are some key points that I wanted to discuss. The first would be risk stratifying the patients, the post-op patients, and the next would be proactively monitoring for recurrence of disease, and the last would be discussing treatment options for the high-risk patients. Oops. Okay. And the first point would be the risk stratification, and the first point that we all need to know is that many patients actually do develop a post-operative recurrence. And clinical recurrence at 5 years is reported to be around 30 to 50%, and at 10 years that rate can go actually as high up to 60%. And endoscopic recurrence, which is always a precursor of clinical recurrence, is as high as 50% at 3 months post-op, and at 1 year, one study mentions that nearly 80 to 90% of patients developed endoscopic recurrence. So the first thing that we all need to keep in mind is that actually post-operative recurrence in Crohn's disease is very, very common. And then we all have to learn about the risk factors that can lead to post-operative recurrence. And the first risk factor is previous surgical resection. And especially one study mentioned that patients who had many surgeries, that's polysurgery, those patients had higher risk of post-operative recurrence. And next is penetrating disease. Like in our patient, the patient had an enterocutaneous fistula. Patients with penetrating disease or internal fistulas, they have a higher risk of post-op recurrence. And the next risk factor is perianal disease. Patients who have perianal development, they have higher risk of post-op recurrence. And also a younger age of diagnosis. As you can recall, there's a Montreal classification for Crohn's disease, and that divides patients' diagnosis to prior to 20 years and 20 to 40 years and above 40 years. And patients who are diagnosed at a younger age, especially during the teenage years, they have a higher risk of post-operative recurrence and having aggressive disease. And also patients who continue to smoke after surgery, they have also a higher risk of recurrence. And actually among those, smoking is actually the only modifiable risk factor. So always try to convince the patient into quitting smoking. And the next is the Root-Gilt scores. Dr. Sophia briefly mentioned about the Root-Gilt score, and it's actually a score that's graded from 0 to 4, and 0 is no endoscopically visible lesions, and score of 1, Root-Gilt I1, is having less than 5 small abscess lesions. And these patients, based on the original study by Root-Gilt in the 1990s, had only about less than 10% of risk of clinical recurrence in the next 10 years. And then the score goes up to 2. Root-Gilt I2 is having more than 5 abscess lesions or larger lesions confined to the anastomosis. And what's characteristic of this Rutgers I2 score is that you don't only look at the neo-TI, but you also have to carefully assess the anastomosis. And if the patients have like large ulcerations, ulcerations confined to the anastomosis, that actually is counted as Rutgers I2. And these patients have nearly 40% risk of having a clinical recurrence in 5 years. And then the score goes up to 3 and 4. 3 and 4 are both diffuse ileal inflammation. And the difference between Rutgers I3 and 4 is that 4 has diffuse inflammation with large ulcers. And in addition, in some cases, those cases who have anastomotic recurrence, they have anastomotic narrowing, or sometimes even both. And if you have a score of above 3 or 4, the risk of clinical recurrence is as high as 50 to 100% in 5 years. And the next point is that we always try to proactively monitor the disease recurrence, and including those with the score, the Rutgers I2 score, the Rutgers score that I just mentioned. And I wanted to bring up one important study that was published last year in Lancet. And the study was stratified those patients into active care group and standard care group. Active care group is the one that we are going to emphasize, scheduled colonoscopy at 6 months post-op, and the standard care is the old-fashioned one where you don't do any post-op colonoscopy. And they also further stratified the patients into high-risk group and low-risk group based on the risk factors that I just mentioned: smoking, perforating, penetrating disease type, and also patients with previous surgery were stratified into the high-risk group. And all patients received 3 months of post-op metronidazole, which is reported to reduce endoscopic recurrence up to 3 to 6 months. And the high-risk patients, they were started on thiopurine treatment because they were considered high risk. And if they were thiopurine intolerant, they were directly given adalimumab right after the post-op. And these active care patients, when they had active endoscopic recurrence at their 6 months post-op endoscopy, post-op colonoscopy, if they were not on therapy, and then they were given thiopurine, they were started on thiopurine, stepped up to thiopurine. If they were already on thiopurine, they were given adalimumab. They stepped up to adalimumab every 2 weeks. And then if they were at high risk and already started on adalimumab every other week, then they were stepped up to adalimumab every weekly. So based on the 6 months colonoscopy findings, the high-risk patients were given stepping up therapy based on the findings. And then all patients underwent endoscopic assessment at 18 months after the surgery, and the findings were assessed compared to the initial high-risk patients and initial proactive group compared to the standard group. And as you can see in this graph, the patients in the active group, the patients in the active monitoring groups, they had higher chances of achieving endoscopic remission compared to the graph in the right, where the endoscopic remission was less compared to the proactively monitoring group. And also, the above graph is the Rutgers I0 and I1 score. The below graph is the Rutgers I0 score. And you can also see that the patients in the proactively monitored group had higher chances of achieving a complete mucosal healing, which was defined as a Rutgers I0 in this study. And then next, I'd like to discuss about the potential treatment options for the high-risk patients. And first, I don't think nobody that often uses mesalamine for Crohn's disease, but similar to active disease, in post-op Crohn's disease, mesalamine actually do not have much role. It does not reduce the rate of endoscopic recurrence, and it only has a very, very small reduction in clinical recurrence at 12 months. The number needed to treat is, I recall it was above like 15. So it barely has any effect in preventing post-op clinical and endoscopic recurrence. Then metronidazole, I mentioned that all of the patients in the previous study were given metronidazole for 3 months, and there were a couple studies, a couple randomized control studies done like 10, 15 years ago, which mentioned that metronidazole can reduce the risk of endoscopic recurrence at 3 to 6 months. But practically, I barely have any patients that can tolerate metronidazole for like more than like 6 months or 12 months. So I don't routinely introduce this into my practice. And then next is thiopurines, azathioprine and mercaptopurine. It does have a modest protective effect against endoscopic recurrence compared to placebo, but the studies were done only up to like 12 months, so the unclear long-term benefit remains a little bit unclear, but it does prevent endoscopic recurrence. And then the biologics, anti-TNF agents, has been on the market for more than 15 years, and the most studied one is infliximab, and it does lower the rates of endoscopic and histologic recurrence compared to placebo. There was a small placebo-controlled study done about 6-7 years ago, and the same group did a multi-center randomized control study in nearly 200 patients, and that was recently published in Gastroenterology, and they mentioned that it does prevent endoscopic and histologic recurrence, which was much greater than placebo. And the follow-up study from the initial study mentioned that that effect can last up to 5 years after the surgery. So infliximab does appear to prevent endoscopic recurrence up to 5 years after the surgery. So it does have a long-term benefit. And adalimumab, which has been in the market for, I believe, 8 years or so, it does lower the rates of endoscopic recurrence compared to thiopurines at 6 months. It was a randomized study. It wasn't a placebo control. I think it was a randomized control study, but it was, and it did mention that adalimumab reduces endoscopic recurrence 6 months after the surgery. And combination therapy in refractory Crohn's or colitis patients, we always discuss about combination therapy of anti-TNF and thiopurines. And there's been no randomized control study done in the post-op setting, but a couple retrospective observational studies suggested that it is potentially more beneficial than monotherapy in the post-op setting too. But no randomized studies have been done, so it's not such evidence-based as compared to the infliximab studies. And we now have anti-integrin agents available. Natalizumab has been on the market for nearly 8 years, but it's not so popular because of the risk of PML. And 2 years ago, vedolizumab became available, which does not carry the risk of PML. And it's been gaining popularity in the refractory colitis and Crohn's patients, but it hasn't yet been studied in the post-op setting, and there's insufficient evidence yet to support the use of vedolizumab in this setting. So this is a brief figure showing the strategy for post-operative surveillance. And the first is to assess individual risk of the post-operative surgical recurrence in each patient. And if you would need to divide the risk to low risk, moderate risk, high risk, and potentially highest risk. Low risk means that there are no risk factors, and moderate risk means that the patient has 1 or 2 risk factors. High risk means more than 2. Highest risk means multiple risk factors, and potentially the patient has already failed thiopurines or anti-TNF preoperatively. And the therapy in these settings would be, if the patient is defined to be no risk, no or very low risk, then potentially you wouldn't give any therapy, or if you believe in mesalamine, you can give mesalamine and then do a 6-month colonoscopy. If the patient was deemed moderate risk, you would start them on a thiopurine. If the patient is deemed defined as high risk, then you would give them anti-TNF with plus minus thiopurine. And if the patient has multiple risk factors, higher risk, then you can directly start the patient on anti-TNF and potentially with thiopurine based on those observational studies. And the important thing is that you always need to do a colonoscopy 6 months after the surgery, and then assess the endoscopic findings in the neo-TI and anastomosis. And if the patient has a root GIT score of 0 or 1, then the patient is in a good condition. You would just continue the same therapy that you were doing prior to the colonoscopy. If the patient has an endoscopic recurrence score of above 2 to 3 or 4, then you need to step up the therapy. And if the patient was initially on no therapy, you could potentially go up to a cypurin, or if the patient already has evident clinical recurrence or aggressive, like a score of like 3 or 4, then I think it would be reasonable to step up to an anti-TNF2. And in moderate risk patients, if the patient has endoscopic recurrence of 2 or greater, then switching to or adding an anti-TNF would be reasonable. If the patient in the high-risk group had endoscopic recurrence, then increasing the amount of anti-TNF agent or potentially switching to another biologic, such as vedolizumab, would be reasonable because the patient already has active disease and vedolizumab potentially can treat active disease. So if the patient already has recurrence at the 6 months post-op therapy, then you would just go on and treat the active disease as usual. And if patients on the highest risk group have a 6 months post-operative recurrence, then you need to increase the anti-TNF agent or switch to a different class such as vedolizumab. And of course, I'm not going into the measuring of the drug level of or checking the anti-drug antibody level, but of course you can always incorporate that into this practice. Okay. And this is the summary of our presentation today. And first is the important thing is to risk stratify the patient. Always assess the risk factors for disease recurrence in patients undergoing surgery. The next is you shouldn't wait until clinical recurrence. You always have a proactive monitoring strategy and actively adjusting medical management based on those endoscopic findings. And always be proactive. Anti-TNF therapies. Anti-TNF therapy is effective for preventing post-operative recurrence. Okay, thank you so much.